Hi, my name is Adam Lipworth. I'm the chair of the Division of Dermatology at the Leahy Clinic, Leahy Hospital and Medical Center, now called, and the director of the Leahy Skin Infection Program. We're going to be talking today about dermatology, key cases for the internist. I am a shareholder in Modernizing Medicine, which is a dermatology-based EMR, and it has really nothing to do with this talk. We will be discussing some off-label use of medications. The plan today, we're going to talk about a couple of common management controversies for skin infections. We will focus on some overlooked or underappreciated diagnoses, especially in the second half of this talk. And all throughout, we're going to pepper the talk with some diagnostic pearls that you cannot easily find on Google. But first, we have to address the elephant in the room. Hopefully by the time you see this, it won't be as big an elephant, but COVID-19. So there are an increasing number of reports of cutaneous manifestations of COVID-19. This was a nice pre-proof that came out just a few weeks ago, summarizing the literature to date. It is rapidly changing, however. I'm going to focus here on just a couple of these themes, so not everything on this busy slide. So number one, there have been a couple of reports now, actually, of varicella-like eruptions, so papules and vesicles, especially on the trunk. This is actually the largest case series that's been reported yet of these varicella-like eruptions in patients with COVID, often young patients. Urticaria, often quite dramatic appearing urticaria, like in this picture, have been reported in a number of case reports. Petechiae have also been reported in a number of reports, often in the dependent areas. And then a diffuse, non-specific eruption, a morbilliform eruption, or what's often called the maculopapular eruption that we see in so many different viral infections. Not surprisingly, has been reported with COVID as well. And then there's a whole category, an additional category of cutaneous manifestations that are vasculopathy related, associated with COVID. The most well-known of these, actually I'll show you in just a moment. This is a common condition in general. So livido reticularis, that net-like pattern, has been reported with COVID. But the most common one is what's been referred to now as COVID toe, which are these perniosis-like lesions or chilblains-like lesions, these purpuric papules, macules, and sometimes even vesicles on the toes and sometimes the fingers, so the acral surfaces, the ends of the body. That looks a lot like what we see in the wintertime with perniosis, but these are happening in warm climates in the spring and summer as well. And there is a wide array of additional rashes still being reported that may turn out to be true associations. They may not be true associations, but if you see an unusual rash in a patient with any symptom of COVID, obviously consider it as a possibility at this point. So this is just a summary slide for reference of the key cutaneous manifestations of COVID-19 so far. Urticaria, morbilliform eruptions, those are the non-specific rashes that we see with a number of different viruses, a varicella-like exanthem, perniosis or chilblains-like lesions of the feet and toes, and then other markers of vasculopathy like livido and gangrene as well. Let's move on to our first case. So this is a 12-year-old girl with a fluctuant nodule on her right temple. It's been increasing in pain for about a week. She has HIV, congenital HIV. CD4 count was greater than 200 and on antiretrovirals, but we knew very few other details. She didn't know them herself. She came in with her grandmother. This was a patient I actually met in Botswana. And so I did not know if her CD4 count was 200 or 500 or 1,000. We didn't know. She had this fluctuating nodule, as you can see, over the temple, and it had a number of similar lesions over the past year. And if you look closely, you can see this purulent material coming out of it. And in the background, we have a number of little follicular papules and pustules. So I'm not going to ask you what this is. This is an abscess. This is a furuncle, which is an abscess around a hair follicle. It's in the setting of folliculitis, so she has lots of folliculitis in the background, and sometimes they form a larger abscess. I'm also not asking this question. So you can look at it. This is a question I used to ask in these talks, and for a very specific reason that we're going to go over, I'm actually not asking you to think about the answer just yet. So what is the most appropriate next step in management of the furuncle? And the options here are just an antiseptic wash, oral antibiotics, incision and drainage. And the answer was, it used to be incision and drainage. And the reason that is not fair and not a fair question anymore is something that's worth talking about for a moment. So when we think about abscesses and furuncles, all of them you want to use warm compresses or do an incision and drainage. Those are essentially a given. If it's small, you can try warm compresses. If it's larger, you want to do an incision and drainage. Question though is, do we need to do anything else? And for many years, this was the teaching, that incision and drainage alone is as good as an incision and drainage plus oral antibiotics. And for years, I would give lectures like this, and I would teach that point. And we don't actually know that to be true anymore. A really nicely done study came out in 2017. It was 6 centers around the country, double-blinded, randomized, placebo-controlled. They used very appropriate inclusion and exclusion criteria. They included patients with a single abscess, less than 5 centimeters, uncomplicated, both adults and kids. All of the patients got an incision and drainage. And then they were randomized to either receive clindamycin or trimethoprim sulfamethoxazole or placebo. They enrolled almost 800 patients. They had follow-up on the vast majority of them. They did intention to treat analysis. They appropriately dosed the treatment arms. It was a very nicely done study. And this is a busy slide showing the results, and I'm going to highlight for you what I think is important here. So these numbers in blue that I put in are the differences between the antibiotic groups and the placebo groups in terms of cure rates. And you notice as you scan through them that they're all pretty big, between 12 and about 20%, except for down here at the bottom, where they did not isolate Staph aureus. And I actually think that reflects the one flaw of the inclusion criteria that I noticed. And I think it actually underestimates the impact of the antibiotics. So in their inclusion and exclusion criteria, they didn't have a great way to tell the difference between an abscess and an inflamed epidermal inclusion cyst, non-infectious cause of a lesion that can look very similar to an abscess. And so I suspect that a number of the lesions included in the study were actually not abscesses at all, but epidermal inclusion cysts, and I wouldn't really expect those to get much better with antibiotics. Those are likely reflected in this box down here at the bottom where no Staph aureus was isolated. We would not expect to isolate Staph aureus from an inflamed epidermal inclusion cyst. And so the leftover lesions, the ones where Staph aureus was isolated, is probably a group that is more specific to true abscesses. And you can see there the cure rate was even higher, closer to 20%, 17 to 19% better among the antibiotic group relative to the placebo group. So it's a pretty dramatic difference. Now there is a caveat that's definitely worth noting, and it's buried deep in supplemental table 8. This is the table of the ways in which patients failed. And you notice here, as you look at the definitions of failure in this study, it includes things like worsening of an original lesion or using rescue medications, which is expected. If you try to treat a lesion and it gets worse despite your treatment, I would consider that a failure. But it also includes new infections. So if you treat an abscess on the arm, let's just say, and a patient comes back 28 days later with an abscess on their leg, that would actually count as a failure in this study. Now, that's not necessarily wrong. That is a clinically relevant occurrence that you might want to protect against, but it's not necessarily what everybody means by failure. If you remove those cases from the analysis, if you no longer define that as a failure, if you're only focused on the lesion at hand that got the patient enrolled in the study in the first place, then the numbers look quite different. And the antibiotics have a much smaller effect, probably not statistically significant. So the question really is, what are we treating? Are you trying to prevent a failure in the lesion that you are actively doing an IND to? Or are you trying to prevent a new lesion within 30 days? And depending on the answer to that question, that should weigh heavily in terms of whether you use an antibiotic or not. I'll tell you what I do. This is my practice, my opinion, based on my interpretation of the data. It is not a formal recommendation in any of the studies. I consider an anti-staph antibiotic, but in practice, I do an incision and drainage, and I culture it. If it's not resolved, if the lesion is not clinically resolved by the time I call the patient with the result a few days later, then I will choose an oral antibiotic based on the culture result on the specific sensitivities. On the other hand, If it is resolved, I don't care what the culture result shows in the majority of cases. They don't need an antibiotic, even if it shows something concerning, as long as they are clinically substantially improved. So that's the way I interpret the data. Let's move on to case number 2. This is a 54-year-old woman who came in with 5 days after an excision of a basal cell on her forearm with progressive peri-incisional redness and pain. She had some malaise, a low-grade temperature, 100.5. And again, I'm not going to ask you what this is because it has a purple line around it, so we all know that's cellulitis. It's the universal sign of cellulitis. This is indeed cellulitis. Question here is, which of the following characteristics is most sensitive for cellulitis? Meaning, if you don't have one of these, you don't have cellulitis. Tenderness, fever, leukocytosis, pruritus, or malaise. So the answer here is tenderness. If it's not tender, it's not cellulitis. And that's one of the key points of this talk. Now, of course, there are going to be exceptions like everything. If you have cellulitis on your foot and you have diabetic neuropathy and you can't feel your foot, you're not going to be tender. But if you should be able to feel tenderness, cellulitis needs to be tender. If it is tender, that doesn't mean it's cellulitis. Lots of things are tender. But if it's not tender, it's not cellulitis. That's the key point. We look at management of cellulitis. The big question, at least when you're talking about simple cellulitis, managing with oral antibiotics, is whether to cover MRSA or not to cover MRSA. So to get to that answer, I think you have to do 2 steps first. One, make sure you're dealing with cellulitis. Is this really cellulitis or is it possibly not cellulitis? And then step 2, think about, is this severe or not severe? And only then do you get to the question of which antibiotic to choose. So first question, cellulitis or not cellulitis? Seems simple, but overdiagnosis of cellulitis, misdiagnosis of another entity as cellulitis is extremely common. That's not surprising because cellulitis is a very common diagnosis. So you would expect a fair number of overdiagnoses as well. There were a number of studies that came out around the same time a couple of years ago looking at this issue of overdiagnosis of cellulitis and its impact. And this is one of them. They estimated that there are about 50,000 to 130,000 unnecessary admissions for cellulitis per year based on their data at MGH and Brigham that they were looking at together, Brigham Hospital and MGH. And that came at a cost a few years ago of $200 to $500 million in avoidable healthcare expenditures. It's probably gone up since then. The estimates probably will have gone up since then. So this is very consequential, making sure you have cellulitis. Here is a very rough guide for checking whether it's likely to be cellulitis. If it's not tender, consider an alternative diagnosis. That's the most important thing. If it is tender, then, well, is it bilateral? So consider another diagnosis. The bacteria in one leg can't talk to the bacteria on the other leg. They can't coordinate. And so if you have symmetrical bilateral lesions that look like cellulitis, probably not cellulitis. Very, very unusual to have a true bilateral cellulitis. Is it pruritic? So cellulitis can be itchy occasionally, but it's almost never the primary feature. If the patient is describing itch as their primary feature, it's probably not cellulitis. And is it geometric? Cellulitis should not be a perfect rectangle, like in this picture in the middle, or this shape with fairly perfect lines on top, at least a flat top and a flat bottom. Very unlikely to be cellulitis if it's exhibiting geometric shapes other than circle or perhaps a true oval. These are all alternative diagnoses, and I'd say stasis dermatitis is probably the most common consult we get. We get consulted for cellulitis when it turns out to be stasis dermatitis, so the most common misdiagnosis. Step 2, once you've determined that it's cellulitis, is to consider how severe it is. If it is severe, if the patient's ill appearing, if they have severe comorbidities and you're worried about a deep infection, for example, or if they have physical evidence of a deep infection, then they need to be admitted, observed, often debrided, broad spectrum IV antibiotics. So frankly, it's even though it's a more severe disease, the decisions to make about how to treat them and what to do are actually relatively simple. Somewhat counterintuitively, the management of simple cellulitis is a bit more complicated. You've got some more decisions to make. Which antibiotic? So remember that the common pathogens for cellulitis include group A strep, methicillin-sensitive Staph aureus, and then community-associated MRSA. MSSA and group A strep are going to be susceptible to beta-lactams. Not all beta-lactams, so not first-generation penicillins necessarily, but at least the later generation semi-synthetic penicillins like dicloxacillin, for example, and the first generation cephalosporins should cover all group A strep and MSSA. MSSA and community-associated MRSA will be generally susceptible to sulfa agents, but unfortunately, group A strep is not reliably susceptible to sulfa agents. And the susceptibility to all of the other commonly utilized antibiotic classes will vary. Now, there are exceptions to that as well. Linezolid is going to get the vast majority of simple cellulitis, whether it's MSSA, group A strep, or MRSA, but we don't want to be overusing linezolid because of cost, side effect profile, and none of us want to be the person that created LRSA. So not a good option. Cultures, unfortunately, are not going to help us. They're very, very low yield. So let's go through the data on simple cellulitis, the empiric antibiotic choice to treat it. Now, I'll caution everybody in advance, it is messy and incomplete, but it is getting better. Let's go back as far as 2010. There's a Cochrane review of the available data at the time, and it drew no conclusions. Couldn't say. 2013, a decent study came out, pretty good study out of Brigham and Mass General and Children's Hospital Boston. And they took about 150 patients who came into the emergency rooms with simple cellulitis, and they randomized them to get either cephalexin plus trimethoprim sulfamethoxazole or cephalexin plus placebo. And they found no benefit to adding the trimethoprim sulfamethoxazole. The patients who got just the beta-lactam, even though it does not cover MRSA, did just fine. They did as well as the patients who got an anti-MRSA agent. That study, essentially the same protocol, was repeated on a grander scale around the country, 5 different emergency departments around the country, many more patients, and they found almost exactly the same result, almost to the percent. In 2014, the IDSA released some newer practice guidelines, and they did something that I think was smart and indicated. They divided skin and soft tissue infections for the first time into purulent and non-purulent infections. So purulent would be the abscesses and furuncles for the most part. Non-purulent is the cellulitis, and then on the severe end, necrotizing fasciitis are the main infections there. And it makes a lot of sense to divide them up. They are approached differently. This is what we're talking about here when we're thinking about empiric antibiotics for simple cellulitis. We're talking about this little part of the graph that's not grayed out over here for mild or moderate cellulitis. And I would caution everybody about one piece of this recommendation. And that's here, the penicillin VK or IV penicillin for mild or moderate cellulitis. To justify that recommendation, they cite 6 studies. 5 of them were from before 1996, so before really the height of MRSA, and they were all based on culture data to show that cellulitis is a strep-dominant disease. So their hypothesis is that most cellulitis is caused by strep, and strep is covered just fine by penicillin, and so that is fine for empiric therapy. Again, 5 of their 6 studies are using culture data, which is very skewed data, looking at only a tiny subset of cellulitis that actually turns culture positive. The 6th study did not use culture data. They used serologies and beta-lactam response to conclude that strep was the dominant pathogen in cellulitis. But they lost a lot of patients to subjects to follow-up, and they did not do intention to treat analysis. That's the serology subset of data. And when they did use beta-lactam response, arguing that if a patient responded to beta-lactams, that means it was unlikely to be staph, it was likely to be strep as the cause. But they recommended cefazolin or oxacillin, both of which cover MSSA beautifully. So it may argue against MRSA, but it doesn't argue against MSSA as the cause of cellulitis, and that makes the data much muddier. Also, remember, most people before the advent of antibiotics who got cellulitis didn't die of their cellulitis. So a fair number of people are going to recover anyway, and that's also going to weaken the beta-lactam response as an indicator of the pathogen. Finally, they only included patients admitted to the hospital, which is not a great pool of patients from which to extrapolate conclusions about simple cellulitis and oral empiric therapy for simple cellulitis. So I don't think we know that cellulitis is a true strep-dominant disease. It's very difficult to estimate the contribution of staph. And because of that, I would be very careful using plain penicillin, simple first-generation penicillin as first-line therapy. For strep, I think, for cellulitis, I think we should at least be covering for MSSA, at least get some staff coverage. And so I would argue I agree with all of their other recommendations. I don't personally agree with penicillin as first-line therapy for cellulitis. So it is a moving target, but the data is still improving. There have been studies since 2014. I don't find any of them terribly compelling, and I chose not to present them here. But those studies from actually 2015, the Moran data, is quite compelling. So I would recommend here for anything severe, admit, monitor, broad spectrum heavy antibiotics and debride if needed. Virulent infections, as we talked about earlier, you do want to debride them. And then possibly for systemic, and possibly to consider systemic anti-staph agents. And then we get to non-purulent skin and soft tissue infections, mainly cellulitis. And I do agree a beta-lactam is likely best for most simple outpatient cases, but I'd caution everybody against using a simple penicillin, first generation penicillin. I would encourage everybody to use an agent with that is beta-lactamase resistant. We have two more cases, and they are larger and more important. I'd say are very important. This case in particular, we'll spend the bulk of our remaining time on this case. So I'm going to show you pictures in a moment of a 52-year-old woman with systemic lupus. She was on mycophenolate mofetil and prednisone. She presented unresponsive with a rash on her right leg only to the emergency department. She was fine the night before, and in the ED, she rapidly developed multi-organ failure. This is what she looked like on hospital day 1. You can see her right lower extremity. A few more pictures. And then on hospital day 3. I'll pause here for a second. So this is her leg. And I think the features that are important here are easiest to see in this picture, at least to start seeing. Because audience participation is obviously impossible here, I'm going to describe the lesions rather than putting anybody on the spot. So we have different colors here. So we have macules and patches of different colors. We have a bullae right over here. And then, not surprisingly, where there are bullae, we have erosions. When the bullae rupture, they leave erosions behind. The colors begin to tell a story. So we have erythema. We have red color over here. We have a purple or violaceous color over here. We have some black. I'll go back a picture. I'll show you the black over here. And I'd say there's 2 other colors that are worth noting. In this purple area, this area over here, you can see some gray. And this gray mixed in with purple, almost like purple with gray ash spread over it, is what dermatologists refer to as dusky. It's a sign of impending necrosis. And that's not surprising because black, as we saw here, that's a sign of later stage necrosis. So we have evidence of inflammation, so the erythematous areas, progressing to early necrosis and then progressing to late necrosis. There's another color worth noting here, and it's actually right over here. This is not her normal skin color. This is actually whiter than her normal skin color. The closest thing we have here to her normal skin color is probably over here at the edge of this, at the edge of the photo, the edge of the picture. This lesion here is whiter, and I'm going to show you just how white it is. On the next picture, we're going to rotate this lesion down here, down lower, and you'll see it there, and then you'll see exactly how white it is. So it's now down here at the bottom. It's the same color as we see over here. And if you remove the top layer, if you remove the epidermis there because of a bulla that ruptured, you can see just how starkly white that dermis is. So this tells us more about pathophysiology. Why is that skin white? Well, it's not vitiligo, right? This is not destruction of melanocytes acutely overnight. This is ischemia. This is blanched skin because of profound ischemia. And again, that's not surprising when we think about it. We have inflammation, we have ischemia, and that's leading to necrosis, which we see also in the colors. There's also an important feature that you can't see that I should tell you, but these purple or violaceous lesions are indeed purpuric. When you press on them, they don't blanch, they stick around. So it tells us that there are red blood cells outside of blood vessels. That's what purpura means. Often we associate with vasculitis because that causes red blood cells to leak. It doesn't have to be vasculitis. All it means is that there are red blood cells sitting in the dermis that don't get squeezed away when you push them. So that's the colors. The most important part, though, of this picture, and of all the pictures I've shown you so far of this patient, is the shape. And this is why I'm presenting this case. So notice here that there are completely abnormal parts of her skin right next to much less abnormal parts of her skin. So we have this purpuric violaceous, these purpuric violaceous plaques with bullae right next to erythematous, but not as bad looking skin. And it's separated by a jagged edge, so very well demarcated, very jagged edge separating the two regions. And then we have a region of ischemia, of blanching skin, again, extremely well demarcated, well separated out from the purpuric area by these jagged edges. And if you look back at some of the other pictures, again, you can see here, very well demarcated edge, very jagged as well, between the purpuric areas and the erythematous areas, between the blanched areas and the purpuric areas. Same thing in every picture you can see. This is a little schematic of the vascular supply of the skin. We have perforating arterioles that go up toward the surface of the skin and supply a cone of tissue in the dermis, which is a zone of arterial predominance. And then in between those cones of tissue in the dermis, we have zones of venous predominance, just like in so many of our organs in our body, very similar. And on the surface, that corresponds to these circles that are about 1 to 3 centimeters in diameter. And those are zones of arterial predominance, and in between them are the zones of venous predominance. I'm not a very good artist, but I've tried to diagram it here. So we have this perforating arteriole going up toward the surface of the skin, supplying a cone of tissue in the dermis, and then a circle on the surface. Looking at that en face, you can see that circle on the surface, and where there's one, there are many. And in real life, they're not perfect circles. They're more jagged, star-shaped. We call them stellate patches, star-shaped patches. If you average out all the troughs and peaks, you average out to a circle, but they're not perfectly circular. And again, where there's one, there are many, and this might start to look familiar to some people. So for anybody who doesn't look familiar to, if we put it in a more physiologic setting, it might start looking familiar now. This is the livido or retiform net-like pattern that we talk about in dermatology so often, like livido reticularis, which I'll tell you about in a second. But this is the net-like pattern we see in drug rashes in so many different processes. That's where it comes from. So the first thing that we can see go wrong with the system is livido reticularis, which is when you have accentuation of those zones of venous predominance outside of the zones of arterial predominance on the surface. So you can see here, this patient, the zones of venous predominance highlighted. Most common cause is physiologic. It can be perfectly normal. I'm sure many people watching this lecture get livido reticularis from time to time. It blanches because it's from blood in veins. So when you squeeze it, it goes away and it blanches. So it's not what we're dealing with this patient. This is the first thing that can go wrong in this livido or retiform pattern. But the second general class of things that can happen in this pattern is called retiform purpura. And that is purpura of these same stellate patches of arterial predominance. It's from occlusion of that perforating arteriole. So we have that perforating arteriole going up to the surface, and we put a clot in it. That causes ischemia on the surface, and then early necrosis. We get bulla forming as the epidermis starts to slough off, and then frank necrosis, black, dead skin. So if you have one patch of retiform purpura, you get one stellate patch if one arteriole is hit with that clot. There are multiple, we have multiple, and you can't necessarily see an individual stellate patch as well, but you can still tell what you're dealing with because of that jagged edge. And you can imagine where those perforating arterioles are. There's going to be one somewhere in the center over here, one somewhere around over here, one somewhere over here, one somewhere over here. You can actually see each zone of arterial predominance. So this is another patient with retiform purpura. And I'm going to show you a spectrum of disease with retiform purpura. And the reason it's so important will become apparent in a moment. I can almost guarantee that everybody watching this lecture will see retiform purpura at some time in their career, probably multiple times. And if you can recognize the implications early on, it's very, very important, and you can stand to do an awful lot of good for that patient. So this is a different patient with retiform purpura. This is actually a few days after he had vasculitis actively. So he's in the recovery phase now, but you can just see so nicely here how there's completely normal skin right next to completely abnormal skin where the entire epidermis is gone. And he's going to ulcerate. He has to just heal in slowly from the sides. And so an arteriole was hit over here and it was skipped over here. and lots of arterioles were hit over here, and then few were spared, and one was hit over here, and then a few more were spared, and then for some reason one was hit over here. For whatever reason, the vasculitis impacted some of these perforating arterioles and not others. And you can see exactly where they lie in the skin. So back to our patient. So if we look at her leg again, now you can start to see that shape. You can imagine exactly where each of these perforating arterioles are that were hit by this process that put a clot in them, caused them to clot off. Again, that original picture that we paused on, look at that jagged edge now and try to imagine where each of those perforating arterioles is at the center of each one of these 1 to 3 centimeter stellate patches. So let's think about her. I'm going to take you through her differential, and her actual diagnosis is going to be less important in the end than the differential. So she has lupus, as I mentioned. She was immunosuppressed. When she presented to the ED, she was very ill, terrible vitals, fever of 105 almost, pulse in the 140, systolics in the 80s, unresponsive, rash on the right leg. She had leukopenia, anemia, thrombocytopenia. She had acute on chronic renal failure. She was very, very ill. So let's think about her differential. If we think about the differential for retiform purpura in general, all you have to do is think about what can cause a clot in a relatively small arteriole. So these perforating arterioles, it has to be either an in situ thrombosis or an embolism by definition. If it's an embolism, it can be any embolism. It can be cholesterol emboli, amniotic fluid emboli, any emboli can cause it. If it's in situ thrombosis, I find it useful to further subdivide that into either a hypercoagulable state or vasculitis. And then I also find it useful to subdivide vasculitis into the inflammatory vasculitides that we often think about, but also to remember septic vasculitis, so an angioinvasive organism causing the vasculitis and the red cell extravasation. So what this means is that the second you recognize retiform purpura, and remember, you only need your eyes to diagnose retiform purpura, nothing else, you don't need any other tools. The second you diagnose retiform purpura, you know right then and there that this patient either has an embolism, a hypercoagulable state, septic vasculitis, or an inflammatory vasculitis. This is a busy slide. I'm not going to read off all the possible diagnoses that can cause retiform purpura, and this is not fully comprehensive, although it's close. As you read through them, I'd like you to notice 2 things. Number 1, nothing on this list is primary cutaneous. Everything here is a systemic disease that happens to affect the skin. And number 2, they're all bad. You don't want anything on this list. Okay? And nothing on that list is primary cutaneous and everything is bad. Now, this patient that I'm showing you, we know she has something bad, right? She's gravely ill, presented to the ED unresponsive. But not every patient who presents with retiform purpura presents in that way. Patient might present with a small patch of retiform purpura on their fingertip. And on the fingertip, those stellate patches can be smaller than 1 to 3 centimeters. Can be just a little half centimeter, little ditzel. But if you notice that it's in that net-like pattern and that it's purpuric, that it's a small patch of retiform purpura, that's a Janeway lesion until proven otherwise. And there's a high likelihood that if you can diagnose retiform purpura in a patient who looks well, that they might end up in the ICU within the next 24 to 48 hours, unless you can head it off at the pass. That's why this is so important. You can recognize it with your eyes and nothing more. It has a big, fairly large list of diagnoses, meaning that it's very likely you will see this at times in your career. And if you recognize it early, you can make a big difference for a systemic, sinister disease. So let's look at the differential again with our patient in mind. Again, her actual diagnosis is the least important part of this case. But when I was faced with her in the emergency room, I certainly didn't feel that way at the time. It was quite scary, and we were deciding between 3 radically different diagnoses: catastrophic antiphospholipid antibody syndrome, the so-called thrombotic storm, or TTP. She actually met all criteria for thrombotic thrombocytopenic purpura, or a severe systemic infection, either causing DIC or causing an emboli, or emboli to shower her leg, or seeding her leg and then having her leg having an angioinvasive organism spread along the vessels of her leg rapidly. As it turns out, very quickly, she grew out 4 to 4 bottles of gram-negative rods, and turned out to be serratia marcescens. And this actually was a case of serratia marcescens gram-negative rod sepsis with necrotic retiform purpura of a seeded limb. That's not the part to take away from this. I don't need anybody to remember serratia marcescens sepsis causing retiform purpura. The key thing to take away is to recognize retiform purpura and its implications, and to know, that's a patient that A, should be referred to dermatology for a quick biopsy, often with cultures, and B, should be taken very seriously even if they don't look ill. This is a patient with cholesterol emboli that seeded her limb after a vascular intervention. And again, you can see here completely dead skin, completely necrotic skin, right next to completely normal skin, or minimally affected skin with some inflammation, with a very jagged edge demarcating the two lesions. And you can really make out each stellate patch around the edge, one over here, one over here, one over here, and so forth. Same patient here, you can see it skipped a few vessels and then hit a few others. This patient, if you saw just her distal leg, let's say, all you would know is that it's purpura. And the differential diagnosis for purpura is so massive as to not be very clinically useful. But when you look at the proximal border, which you can see blown up over here, and you see that island of sparing, and you see the edge with these jagged edges between normal skin and abnormal skin, now you know it's retiform purpura, and it has a much more limited and much more clinically useful differential diagnosis. You know there's an embolism or an in situ thrombosis. Another patient, this patient here had DIC, by the way. So it was E. coli sepsis with DIC. This is another patient with E. coli sepsis and DIC, same pattern. Another patient with E. coli sepsis and DIC. And then this is the last patient I'll show you, and I'm always hesitant to show this picture, but I've decided to keep it in because, I'm hesitant because it's a terrible picture. It's out of focus. I was just learning how to use my camera. I was actually a first month resident when I took this picture. But it shows that you don't need focus to diagnose retiform purpura. It's a 20,000-foot view diagnosis. You can see here on her hand that it is lighter in the middle than the outside. There's ischemia, blanching. This is violaceous around the edge of these lesions, and it is indeed purpuric when you press on it. And you can see that jagged border and that shape, that well-demarcated jagged shape that defines retiform purpura. This was a patient with actually multiple hypercoagulable states adding to each other until the point that she started clotting off her perforating arterioles. This is the same patient. You can see here again that retiform purpura. Key points here are to recognize retiform purpura, and then to recognize that it's an early indicator of systemic and generally a malignant disease that you can intervene upon early if you recognize it. Last full case, this is an 18-year-old male that I'm going to show you in a minute, who presented to the ED with a day of worsening pruritic rash on his face. In the ED, he was diagnosed with impetigo, and he was admitted to the observation unit for IV antibiotics. And the next morning, the rash extended to his lip and his eye, and derm was consulted. Note a couple things as I walked down to meet him. First of all, it's not very common for a patient to be admitted to the ED or to OBS for impetigo. And second of all, it's not very common for them to get IV antibiotics. Or for it to extend in a concerning way overnight. What that tells me is that good, well-intentioned, smart doctors were worried about this kid. So I essentially, at that point, was not paying so much attention to the diagnosis of impetigo that was told to me, but I was paying attention to the fact that smart people were worried about him. You look at his face here, and he is very edematous. His eye is closed because he can't actually open his eye. It's so edematous. He can open it, he can pry it open with his fingers, but he can't actually open it spontaneously. You can see on his ear, over here, his earlobe, all this golden crusting, and that's why this was called impetigo. And indeed, he has impetigo. But a key point that I would have said earlier in the lecture, but it got eliminated by the COVID section. A key point is that impetigo should be a secondary diagnosis in adults. Kids can just get impetigo, but adults really shouldn't, including 18-year-olds. It should be impetigo secondary to an abrasion, so a break in the skin that allowed Staph aureus to cause impetigo. Impetigo secondary to an eczematous dermatitis. Impetigo secondary to immunosuppression. So patients who are immunosuppressed can just get impetigo, but it's secondary to something. So yes, he has impetigo. That's not really that important. Why does he have impetigo? So we look around, we see here he's got this edema, he's got this erythema over his face, he's swollen, eye is swollen shut, he's got impetigo all over his earlobe. He's smiling, so he's happy, he felt okay, he just was uncomfortable a little bit, he couldn't open his eye, he was so swollen, but he was not in pain. Let's look in closely, and I'm actually not looking closely here at the impetigo. There are other things to see here that are more important. The first is actually up here in the corner, that my flash from my camera is shining back at me. What that really means is that his skin is covered in fluid. He's wet. His serum is coming through his skin and sitting on top. And then if you look closely, right in front of his earlobe, there's this little cluster of teeny tiny little vesicles. They're smaller than we typically see for herpes. There's no erythematous base. So you could think about VZV or HSV, but it would not be a typical presentation given how teeny they are and how and the absence of a substantial erythema underneath them. There is, I don't know if anybody listening speaks Greek, and this is just kind of a quiz for yourself, but I don't know if anybody knows the root of the word eczema. It's actually, it's Greek, and I learned from somebody I gave a lecture like this to once that it's I believe just ancient Greek, not modern Greek. But it means boiling over. And eczema is actually defined as a 3-stage rash, the acute phase of which is the boiling over phase, where you have so much fluid in the epidermis, something called spongiosis, separating apart the keratinocytes from each other, pulling them apart. The fluid, the serum actually starts to bubble through the epidermis, and you get tiny little vesicles, microvesicles like these guys here. And when they rupture, they leave the serum on the surface. So lots of edema, and then so much so that it actually starts to bubble through. And so this morphology here, these little teeny vesicles, tell you that at least we're in the family of eczema, and that makes sense with the impetigo because staph loves eczema. It feeds off that fluid, and you often get impetiginization of eczema. But eczema is not really a diagnosis in and of itself. We sometimes think of eczema as synonymous with atopic dermatitis, but that's just one form of eczema. There are lots of forms of eczema. And dermatitis, for the most part, is synonymous with eczema, with a few unfortunate exceptions like dermatitis herpetiformis. So for the most part, when we say dermatitis, we mean eczema. We don't just mean skin inflammation. So atopic dermatitis is a form of eczema. Stasis dermatitis is a form of eczema. Nummular dermatitis, contact dermatitis, and so forth. These are all forms of eczema with the same morphology in the acute phase. Okay, so we're diagnosed eczema. Let's try to figure out what kind of eczema he has. We look around the rest of his body, and you start to see these lines of eczema. And then on his flank, we have these 3 almost parallel lines here, maybe one that's not quite as parallel. And then on his other flank here, we have really well-formed lines, and they're not parallel at all. So we think about what can form these lines on a body. Your body doesn't know what a line is. And those are dermatomal lines, I suppose. This is clearly not dermatomal, for example. So line means outside job. Something from the outside contributed to forming this line. Now, could be a fingernail. You can see excoriations cause lines, so the outside component could be the fingernail, essentially, which is outside of the abdomen. But when we scratch, it's human nature, we usually scratch in a parallel fashion. It's very unusual to scratch like this and then suddenly scratch like that. It's just not as common, this is one finger. But when we see lines that are just arranged perpendicularly to each other or arranged at different angles like this, it's usually not going to be simple excoriation that's causing it. So we have an eczema, and we think that it's caused by an outside job. By far, the most common cause of that is poison ivy. Now, this was indeed a case of poison ivy. He was in the observation unit of the ED, as I mentioned. 40 feet away, in the alpha unit of the ED, was his girlfriend, looking exactly the same. As it turns out, the two of them had been rolling around in the park the day before. They had gotten really severe, terrible poison ivy together. They both went to the ED separately. She went to the alpha unit, he went to the obs unit. His team consulted derm, her team consulted allergy. The two of us met halfway between the 2 units of the ED, exchanged notes, realized we knew more or less what was going on already, but you can see here on her, you can see the eczema on the line as well. So this was a severe allergic contact dermatitis due to poison ivy that was impetiginized, and that's what actually resulted in the admission. I'm going to skip that slide and just move on to this semi-case, which we will end with. This was a 44-year-old male, healthy, who developed a lesion on his forearm. I never saw it. This was 3 weeks before this picture was taken, or 2.5 weeks. He talked about it to his uncle, who was a primary care doc, and the uncle gave him cephalexin. It didn't get better, so about a week later, he went to his primary care doc, and primary care doc said it looked like a cellulitis and gave him clindamycin. It didn't get better, so he went back a few days later, and it was cultured, and he was started on trimethoprim sulfamethoxazole for presumed MRSA cellulitis. A few days after that, he went to the emergency room and was admitted for MRSA cellulitis. The culture to that point was no growth to date. And the plan was for PICC line, for you started getting IV vancomycin, the plan was for PICC line and home for 2 weeks of IV vancomycin. He actually insisted on a derm consult, and that's why I met him. When I met him, if you remember back to the first case, you can think about what my first exam maneuver would be. So this is thought to be cellulitis. The first thing I'd do is press on it. And it was not tender. So right there and then, abort the PICC. If it's not tender, it's not cellulitis. So we don't necessarily know what it is yet, but we know that it's not cellulitis. He doesn't need a PICC line to go home with. Okay, we look more closely. What is it if it's not cellulitis? And we see this edematous pink plaque. And in the middle is an erosion, a large erosion. And around the edge of that erosion are teeny tiny little erosions. And when we see teeny tiny little round erosions, we think about teeny tiny little vesicles that rupture to create those teeny tiny round erosions, something else we talked about earlier. This case is kind of bringing a lot of things together from earlier in the talk. There's a lot of golden crusting, and that fits with Staph aureus feasting on fluid that's coming out of these erosions and these tiny microvesicles. You know, it's not tender. So this is starting to really seem like an eczematous dermatitis, an acute eczematous dermatitis. And in fact, it was itchy as well. Why does a healthy 44-year-old guy have an acute eczematous dermatitis bad enough to get him admitted and to create a plan for PICC line with IV vancomycin? Well, think about what many of us do when we get a lesion that we think is an infection on our arm or anywhere on our skin. Very common thing to do is to apply triple antibiotic ointment, which has neomycin in it, which is the, well, let's start with bacitracin. It's bacitracin in it, which is usually about number 5 most common cause of allergic contact dermatitis in the country. And has neomycin in it, which is usually about the number 2 or 3 most common cause in the country of allergic contact dermatitis. 2 of the top 10 are both in triple antibiotic ointment. So very, very common to see allergic contact dermatitis from triple antibiotic ointment, which he had been applying since day 1, even before he talked to his uncle about the lesion. And so this was another case of allergic contact dermatitis. And this one was misdiagnosed as cellulitis. He was sent home an hour later with clobetasol topical steroid instead of with the PICC line. And this is the final picture in the same vein. This patient also had been admitted to the hospital for a week by the time I met him with otitis externa. This is diagnosis. Wasn't getting better. And I wish I had a picture of his other ear, because this ear is literally twice the size of his other ear. It was massively, massively edematous. But when you mash on it, when you squeeze the ear, it does not hurt. It doesn't fit with otitis externa. It doesn't fit with cellulitis. It wasn't painful when you pressed on it. What's going on? His family was really doting. They read up about otitis externa, and they learned that it was often caused by a bacteria called Pseudomonas, and that Pseudomonas often responds to antibiotics, including neomycin and polymyxin B or colistin. And so they were sneaking in triple antibiotic ointment and putting on about 5 times a day in the hospital onto his ear, as his ear got progressively worse and worse and worse. And he also went home about an hour later with clobetasol. So the take-home points here are: cellulitis is tender. There's recognized retiform purpura. You will see it at times in your career. And triple antibiotic ointment causes allergic contact dermatitis often. And I thank you all very much for your attention, and hope to see you in person in the future.